Namaste Betiya, Hamisha Khush Raho Betiya. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to discuss about hepatitis B. In the last lecture, we had discussed about hepatitis introduction and hepatitis A. And in today's lecture, we are going to discuss about hepatitis B, its etiopathogenesis, the clinical features, investigation, and management. So let's start with hepatitis B. Hepatitis B is a viral infection that attacks the liver, and it can cause both acute and chronic disease. So hepatitis B, it is a viral infection, and it is affecting the liver, and it is causing both acute and chronic liver disease. Now, hepatitis B is caused by hepatadenovirus, and which is the outer surface coat that contains hepatitis B surface antigen in a nucleocapsid core that contains hepatitis B core antigen, DNA polymerase, and partially double-stranded DNA genome. There are circulating form of hepatitis B. Core antigen is hepatitis B E antigen. Is a maker of viral replications and infectivity. So there are multiple serotypes and genetic heterogeneity. The onset of hepatitis B infection is usually insidious or it can be acute. So in hepatitis B, it is basically a viral infection that is caused by hepatitis B virus, and it is affecting the liver. It can cause both acute as well as chronic disease, and it is caused by the hepatadenovirus with the outer surface coat, that is HB, hepatitis B surface antigen, in a nucleocapsid that contains HB, hepatitis B core antigen, DNA polymerase, and partially double-stranded DNA genome. There are multiple serotypes and genetic heterogeneity that we are going to see in case of hepatitis B virus. The onset of hepatitis B can be insidious or it can be acute. The age, the young adults of who are involved in excessive sexual activity or taking percutaneous needles or injections, those who are drug abused, and babies and toddlers are the most common age group that is affected. So most commonly it is seen in the patients of the individuals of the young adult group that are very much sexually active, as well as who are taking drugs, percutaneous drugs through the needles. Now, hepatitis B virus, the DNA codes for 4 sets of viral products. So in the hepatitis B virus, the DNA is coding for 4 sets of viral products, and it has overlapping genes with S, C, P, and X. So in hepatitis B, the DNA is coding for 4 sets of viral products, and it has 4 overlapping genes which contains S, C, P, and X. The protein product of the S gene is hepatitis B surface antigen. That is a major protein and is referred to as hepatitis B surface antigen, that is HBsAg. So the protein product of the S gene, it is the hepatitis B surface antigen. It is the main protein and major protein, and it is referred to as hepatitis B surface antigen, that is HBsAg. The nucleocapsid protein are coded by the gene C. The antigen expressed on the surface of the nucleocapsid core is hepatitis B core antigen, that is HBcAg. Another product of the same C gene is hepatitis B E antigen, that is HBeAg, that is developed from the pre-core region. So C stand for core region and E stand for the pre-core region. It binds it to the smooth endoplasmic reticulum. So it is binding this to the smooth endoplasmic reticulum, leading to the secretion into the circulation. So there is secretion of the HBe antigen, that is the pre-core region, into the circulation. Next, we have the P gene. The P gene codes for the hepatitis B virus DNA polymerase reaction. and it is the third and the largest of the hepatitis B gene, virus gene. So the third and the largest of hepatitis B virus gene is the P gene. So out of the 4 codes which contain S, C, P, and X, P is the gene that is most common, and it is the largest of the gene that is present. It has DNA polymerase and an RNA-dependent reverse transcriptase activities. So it has DNA polymerases and the RNA-dependent reverse transcriptase activities. The 4th gene, X, it codes for small non-particular protein. So the 4th gene, X, is it is coding for a small non-particulate protein with the hepatitis B X antigen, which contain HBX antigen, and it affects the calcium release from the mitochondria, which activates the signal transduction pathway. So it is activating the signal transduction pathways. The sources, what are the different sources of transmission of hepatitis B virus? As we have discussed in the hepatitis A virus, it was due to fecal-oral transmission, and that was seen in the overpopulated and the places that were not properly sanitized. Now, the sources of hepatitis B virus infection, it can be spread via 2 ways. One is the vertical transmission, and second is the horizontal transmission. Vertical transmission takes place from the infected mother to the child. So HB surface antigen positive, mother to the child. This takes place in 90% of the cases. Whereas horizontal transmission occurs in around 10% of the cases. It is seen with the injection drug users, those people who are taking too much injections through the drugs through the injections, infected unscreened blood products. If the blood is not properly screened and is transmitted to the other individual, then it can result into the spread of the hepatitis B virus. Tattoos and acupuncture, needles. So through the needles of tattoo making and acupuncture, this can spread through the sexual intercourse. So those individuals who are involved in excessive sexual indulgence, because it is common in the adults. So those who are homosexuals or heterosexuals, in both the individuals, hepatitis B virus infection can spread can take place. So the sources of infection of hepatitis B, there are 2 types of infection. One is vertical and the other is the horizontal. In the vertical, the transmission is from the infected mother to the child, and in the horizontal transmission, there is it is transmitted by the use of injection drug use, infected unscreened blood products, tattoos or acupuncture needles, and sexual intercourse, both homosexual as well as heterosexual. The incubation period of hepatitis B infection, that is the time from the entry of the hepatitis B virus into the body to the production of symptoms, to the clinical features that are appearing, is around 30 to 180 days, means 8 to 12 weeks. The mean timing of 8 to 12 weeks, although it can take time from 1 month to 6 months, 30 days to 180 days. Now we come to the clinical features. Whenever a patient of hepatitis B virus is coming to us, then what are the clinical features with which the patient can present to us? The clinical feature will constitute of constitutional symptoms and the symptoms of chronic hepatitis. So in the constitutional symptoms, the patient can present to us with the symptoms of anorexia. There will be anorexia, nausea and vomiting, fatigue, malaise, arthralgias, myalgias, headache, photophobias, pharyngitis, cough and coryza that precedes the onset of jaundice by 1 to 2 weeks. So the constitutional symptoms includes anorexia, nausea, vomiting, fatigue, malaise, arthralgias, myalgias, headache, photophobias, pharyngitis, cough and coryza that precedes the onset of jaundice by 1 to 2 weeks. So first of all, these symptoms will be present, then the patient will complain of the jaundice. The nausea, vomiting, and anorexia are frequently associated. So the GI symptoms, which includes the nausea, vomiting, and the anorexia, these are frequently associated with the alteration in olfaction and taste. So there will be nausea, vomiting, and anorexia with the alteration in the olfaction and taste. Hepatitis B is heralded by serum sickness-like syndrome. So with hepatitis B virus infection, there are symptoms of the serum sickness that are characterized by the arthralgias or arthritis. So the patient can have arthralgias, he can have arthritis. There can be rashes with angioedemas, and rarely hematuria and proteinuria may develop. So with hepatitis B, there can be symptoms like arthralgias or arthritis. There can be rashes, angioedema, and rarely hematuria and proteinuria can develop in around 5 to 10% of the patients. The fever, the patient will also complain of fever that will range from 39.5 degree Fahrenheit to 40 degree Fahrenheit. So 39.5 to 40 degree Fahrenheit fever can be present in the individual, that is around 103 to 104 degree Fahrenheit, 39.5 to 40 degrees Celsius, sorry, and it is around 103 to 104 degree Fahrenheit. The urine is dark and clay colored stool is noticed in the patients from 1 to 5 days before the clinical onset of the jaundice. So before onset of the jaundice, the patient will complain of dark colored urine and clay colored stool. The patient will have fever from 39.5 to 40 degrees Celsius or around 103 to 104 degree Fahrenheit. And there will be symptoms like arthralgias, arthritis, rashes, angioedemas, and rarely hematuria and proteinuria. The liver becomes enlarged and tender, and it is associated with the right hypochondriac or the right upper quadrant pain and discomfort. So there will be pain and discomfort in the right upper quadrant of the body, of the abdomen, and splenomegaly and cervical lymphadenopathy are present in around 10 to 20% of the patient. There, you can also see spider angiomas. Spider angiomas are basically blood vessels that are looking like this spider web. I have given the picture of this particular disease condition in the e-notes, so you can refer to those e-notes. So we can see spider angiomas that appear during the icteric phase and disappear during the convalescence. So during the icteric phase, the spider angiomas are developing and these are disappearing during the convalescent phase. The fulminant hepatitis is seen primarily with the hepatitis B, C, and B, D, and E. So you can see the fulminant hepatitis with hepatitis B, D, and E. Next, we come to the chronic hepatitis. Chronic hepatitis, so first one was the clinic constitutional symptom. Next are the symptoms of chronic hepatitis that are seen with the hepatitis B virus. So chronic hepatitis, it is the most important late complication of hepatitis, acute hepatitis B. So first of all, acute hepatitis B is developing. Then in the late complication, we can get acute chronic hepatitis B infection. The chronic infection without having experienced an acute illness. So this can be present without experiencing the acute illness, and directly after too much time after getting infected with hepatitis B virus, directly chronic hepatitis stage can appear. It will be characterized by the symptoms, constitutional symptoms like anorexia, weight loss, fatigue, and persistence of hepatomegaly. So in the chronic hepatitis, the patient will complain of anorexia, weight loss, fatigue, and persistence of the hepatomegaly. There will be presence of multilobular hepatic necrosis on liver biopsy. So whenever we are going for liver biopsy, we are going to see multilobular hepatic necrosis on the liver biopsy. The failure of the serum aminotransferase, bilirubin, and globulin level to return to normal within 6 to 12 months after the acute illness. So after the acute illness is over, the serum aminotransferase, bilirubin, and globulin level comes to normal within 6 to 12 months. And there will be persistence of the HBe antigen for greater than 3 months or HBs surface antigen for greater than 6 months after the acute hepatitis. We have another condition, that is fulminant hepatitis. Fulminant hepatitis, fulminant means that is coming very aggressively, or there is massive hepatic necrosis. So encephalopathy that may evolve to deep coma. So fulminant hepatitis is characterized by encephalopathy that may evolve to deep coma. The liver is usually small and the prothrombin time is excessively prolonged. There is combination of rapidly shrinking of the liver size with rapidly rising bilirubin level. So there is shrinking of the liver size with rapid rising of the bilirubin level. Marked prolongation of the prothrombin time can be seen. Aminotransferase level falls, and together with the clinical signs of confusion, disorientation, somnolence, ascites, and edema can be seen. So there can be aminotransferase, its level falls, and together with the clinical features of confusion, disorientation, somnolence, ascites, and edema can be seen. There will be cerebral edema that is common with brainstem compression with gastrointestinal bleeding, sepsis, respiratory failure, cardiovascular collapse, and renal failure are terminal events. So in case of fulminant hepatitis, we can see cerebral edema that is common. There can be brainstem compression with gastrointestinal bleeding, sepsis, respiratory failure, cardiovascular collapse, and renal failure. These are the terminal events. what are the investigations that could be done in case of hepatitis B? We have to screen for the hepatitis B surface antigen in the serum in the acute and chronic infections, especially antibodies with IgM, anti-hepatitis B core antigen. Serum aminotransferases and aspartate aminotransferase level is increased, and this has to be checked. AST and ALT increases to a variable degree. There will be rise in the bilirubin level. The prothrombin time will be prolonged excessively. There will be diffuse but mild elevation of the gamma globulin fraction. And serum IgG and IgM level are elevated in about 1/3 of the patient during the acute phase. So in the investigation, we have to search for the surface antigen, hepatitis B surface antigen. We also have to check for core antigen. Serum aminotransferases and aspartate aminotransferase, AST and ALT will be raised to a variable degree. The bilirubin level will be raised, the prothrombin time will be increased, and there will be mild elevation of the gamma globulin fraction. Serum IgG and IgM levels will be increased. Now, how to manage a case of hepatitis B infection? The management in most of the cases of typical acute viral hepatitis, specific treatment is generally not necessary. So we have a common set of treatment for all the variety of the hepatitis. Some of the management we have discussed in the previous lecture. Hospitalization may be required for clinically severe illness. So if there is any severe illness, then only we can go for hospitalization. Otherwise, there is no hospitalization required. A high calorie diet is required. There will be transvenous feeding in the persistent vomiting. The drugs metabolized by the liver should be avoided. So those drugs that are metabolized through the liver are avoided in order to prevent excessive load on the liver. The treatment with a nucleoside analog at oral doses are used to treat chronic hepatitis. Interferon alpha, lamivudine, edifovir, entecavir, and tenofovir is usually given. If the condition is not treated, then we can go for liver transplantation, and HB, hepatitis B immunoglobulin or a recombinant vaccine can be given. Now, how to manage a case of fulminant hepatitis? In the fulminant hepatitis, the goal of the therapy is to support the patient by maintenance of the fluid balance, the support of the circulation and respiration, control of bleeding, and correction of the hypoglycemia. So in the fulminant hepatitis, the goal of therapy is to support the patient by maintenance of the fluid balance, the support of circulation and respiration, and control of the bleeding, and correction of hypoglycemia, and treatment of the other complication of the comatose state in anticipation of the liver repair, regeneration, and repair. So we have to manage certain conditions by fluid balance, support of circulation and respiration. We have to control the bleeding and correction of the hypoglycemia. Now, what is the outcome of hepatitis B infection? 95 to 99% of the previously healthy adults have a favorable course and recover rapidly. So out of the 100% patient coming to us, 90 to 95% of the patient, 99% of the patients have a favorable course. The patients with advanced age and with serious underlying medical disorder may have a prolonged course. So the patient which are having advanced age and serious underlying medical condition, they can have a prolonged course. Ascites, peripheral edema, and symptoms of the hepatic encephalopathy suggest a poor prognosis. The patient ill enough to be hospitalized for acute hepatitis B, the fatality rate is around 1% in such cases, and hepatitis B accounts for greater than 50% of the fulminant cases of viral hepatitis. So in all of the 100% of the cases of fulminant hepatitis that we are getting, 50% of the cases are because of the hepatitis B virus. So this is all about hepatitis B virus. I think you must have understood the session properly. If you have any query, you can consult my e-notes that I have uploaded on the portal, and you can also check from the book, the matter that is given in your book. So this was all about hepatitis B. In the next session, we will be discussing about hepatitis C, D, and E. So this session is powered by digital version 2.0, JAYOTI VIDYAPEETH Women's University. I hope the session is clear to you and you have understood the things properly. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.